Dear ladies and gentlemen, my name is Elias-Leon Nolden, and I'm a PhD student here at the Translational Medicine Center. My PhD thesis is the implication of personalized medicine in maxillofacial surgery. I'm a dentist as well as a fifth-year medical student, and I'm from the Department of Oromaxillofacial Surgery and Stomatology, as well from the Department of Oral Biology here at Semmelweis University. Our team consists of my supervisors, Mihail Vasilko and Laszlo Köles. My SMS is Alex, and my statistician is Bogi. My vision is to transform maxillofacial care with tailored solutions, and the mission I will provide better clinical decisions based on research. I have two ongoing specific goals. In my first specific goal, I'm comparing the patient-specific implant with the stock system in patients with temporomandibular joint reconstructions, and I'm using here a systematic review and meta-analysis to achieve this goal. So why do we need to replace even the TMJ? Most often indications for TMJ replacements are due to long-standing degenerative joint diseases such as osteoarthritis, as well as traumatic injuries, or due to previous failed conservative or surgical interventions. And untreated, this will lead to pain for the patients, problem with mastications, speech, and also social interaction. And if we look at this figure, we already know that it's approximately 6 years, 5 years now, the necessary amount of TMJ operations will be increased by 60%, which will be just 900 operations per year in the US. And what can we do? We have two possibilities, two alloplastic implants we can choose between. The PSI, the patient-specific implant, which is a fully customized implant for our patient's unique anatomy, or the stock system, which comes in 3 standardized sizes. And today, there's no definitive evidence-based recommendation which of them to choose. That's why our aim is to investigate if the custom or the stock implant lead to better patient results. Our clinical question is, does the TMJ replacement of the custom or the stock system result in better function? And this function is measured by the maximal mouth opening in millimeters, as well as the visual analog scale for pain and diet. And our hypothesis is that the PSI is superior than the stock system in terms of stomatognatic rehabilitation. We conducted our systematic search at the beginning in November 2023, and we were left with 42 articles, including 32 one-arm and 10 two-arm articles. Regarding our first outcome, it is measured by the interincisal distance in millimeter. After operation, mouth opening between 30 and 40 millimeter is considered successful, and for this outcome we could include 40 articles. Here you see the summary plots. On the left side the custom implant, on the right side the stock implant. You look at the pre to post-operative changes due to different follow-up times, starting with a direct post-operative follow-up time, and the bottom is the follow-up time over 4 years. And as you can see, both of the implants work very well. However, none of these analyses could reach a mathematical significance. If we look now at the mean difference between custom and stock, we see a tendency favoring the custom implant almost in all groups. Also, this couldn't reach a mathematical significance neither. If we look now at this figure, also looking at the pre to post-operative changes between custom and stock, we can still see that there might be some superiority for the custom, for the patient-specific implants over the stock system. We wanted to eliminate patient heterogeneity by only looking at the two-arm articles. Here you look at the mean difference between both systems due to different follow-up times, and choosing PSI over the stock system lead in all groups and all subgroups to increased mouth opening. Also reaching a mathematical significance here for the first time after 1 year, favoring the PSI with almost 6 millimeter larger mouth opening. Also, we analyzed the individual patient data, and we found out that being a male and choosing the custom implant leads to a larger mouth opening of 5 millimeter than being a woman, with resulting only less than 1 millimeter after operation. Also, if you are 10 years older during the operation, you can expect less increase of the mouth opening compared to someone who is 10 years younger, and the same for someone who has already initially increased mouth opening of 5 millimeters than compared to someone who has not. Regarding our second outcome, pain, which is measured by the visual analog scale, also here, after operation, of course, a completely pain reduction is considered as a success. And for this outcome, we could include around 2,100 patient data. You look also here at the summary plots. The effect size is the pre- to post-operative changes on this visual analog scale. And also here you see that in all groups and all follow-up times, the pain can be reduced with not reaching any mathematical significance yet. Regarding the mean difference, we have very contradicting results here, favoring first stock, then later custom, then stock again. Again, this might be due to the high patient heterogeneity, which we found during our studies. Here we could also reach mathematical significance in 3 groups. However, this needs to be interpreted with cautions in clinical practice. Also, this figure shows perfectly that in both systems, pain can be reduced. Regarding our last outcome, diet, which is also as pain measured on a visual analog scale, also here we want to have no diet restrictions for our patients after surgery, and this was the outcome with the least included articles. Here we could only subgroup them in 2 follow-up times. The first one at the top until 2 years and the bottom over 2 years. Also here, none of this could reach mathematical significance. However, the mean difference, similar to the pain outcome, so it's very contradicting results for the favoring first custom, then stock, with reaching also mathematical significance for stock after 2 years. In conclusion, both of the systems, the implant system, work very well. However, the PSI seems to show us some superiority in mouth opening with reaching a mathematical significance after 1 year. Outcomes related in pain and diet might be mixed during the different follow-up times. And what we also saw is that the current literature lacks in precision and comprehensiveness. So, yeah. Our summary is that we have, the biggest strength is that we have the biggest patient population, as well as we could subgroup our analysis based on different follow-up times to see potential deviations during the time, during the postoperative rehabilitation. And our biggest limitation is, as I mentioned already, is the big patient heterogeneity due to lack of pathology grading and diagnosis. And also that 2 out of 3 outcomes can only be assessed subjectively. Our implication for practice is that customized should be for those who are lacking of some mouth opening, while the stock implant seems to be a good alternative to address pain and diet management. And the implication for research is that further research should focus on developing and comparing PSI in relation to these limitations such as pain and diet. Currently, we submitted our manuscript to the Journal of Craniomaxillofacial Surgery, and it's under review. Regarding our second project, we are also here comparing patient-specific implants with hand-curved implants in patients with cranioplasty. We are also using here a systematic review meta-analysis to achieve this goal. Why do we need cranioplasty? Of course, cranioplasty protects our brain. In doing so, it increases the brain blood flow and the brain metabolism. That's why it's considered as a standard procedure. However, compared to other routine neurosurgeries, we see this with very high complication rates. And also here, we have the possibility to fully customize our implants as shown on the left side, or we do it during the operation with, for example, titanium mesh, as you can see on the right side of the picture. And also, these non-customized implants often show less aesthetic satisfaction and also then higher complication rates. So our aim is now to investigate in which one of them leads to better patient results. And also here, these patient results we measure by the safety, which is measured by the postoperative complications, as well as the aesthetic and surgery time and length of hospital stay. And our hypothesis is that the PSI is superior here than the hand-curved implants in terms of rehabilitation of the craniofacial system. And our biggest implication will be the long-term implant survival as well as less secondary operations. We conducted also here our systematic search at the beginning of August last year, and we were left with around 51 articles. And currently we are in the phase of data extraction. And in summary, both of my articles are investigating in personalized medicine and maxillofacial surgery, and I would like to thank you with my favorite quote from Eugen Roth: "A human often feels quite transformed when treated humanly and warmly adored." Thank you very much.
At the beginning, you mentioned that this kind of transplantation, or actually implantation, is going to rise. Why is that? Because of more joint diseases, or just because of the number of population is increasing?
Thank you very much for the question. I think both of what you said is totally right. So once due to higher population, as well as we see more and more joint diseases due to rheumatological or hormonal reasons, and this is probably also going to be projected with higher incidences in the next years.
So is it quite often that people are needing replacement of TMJ because of arthritis? How high it was? I didn't recognize that.
So for 2030, it's projected to be 900 operations in the US, which is not very much at all. So it's a very niche topic. I definitely agree with you there. It's also the last option we basically have after everything else failed, such as arthroscopy or minimal invasive surgeries. So it is a very small topic, but however, as there are these two different possibilities, we need to see which one is better or not, because it's also for the hospital, might be in terms of costs or just in time management, very different, choosing the customized ones or the standard, which is basically an implant from the bookshelf. So, yeah.
As I saw that in the first project, you say maybe the stock can provide a cost-effective treatment. Like, is there a big difference in the cost, or was that mentioned in the literature, the difference between the two types of treatment?
Thank you very much. Actually, the implant cost itself nowadays is not so much of a difference anymore due to better development just in general about 3D printing and CAD/CAM. However, which is actually more expensive for the hospital is the inpatient stay. So depending on how long the patients stay on the ward or how long the operation itself is. And this very much varies depending on the complications we have. So we hope that due to the customized or due to the patient-specific implant, you also have less secondary operations, less complications, because you don't need to alter the implant or the patient's anatomy, because you can basically just fit it in. So, and due to all of this, the patient's stay in the hospital will be decreased. This was also already investigated by previous meta-analysis, and that's why we also didn't want to include it now again in our outcomes.
You mentioned in your first project that the mouth opening increased much more for men than for women. Do we know why that is?
Thank you very much for the question. As it was for the woman not statistically significant, this could be once totally random. However, we assume that it might be less because women, or we saw in the phase of data extraction, that women are facing more of these rheumatological diseases which lead to arthritis. So they have more of a systematic problem, while for men often we saw just simple traumatic injuries, so fractures, which are more of a localized problem. So this could be a reason, but besides that, we cannot say it.